Thank you, Dr. Sarvanan. And in the next few minutes, I'll be speaking to you specifically now more about the techniques of membrane dissection in vascular retinopathies. These are my financial disclosures. So membranes on the retina occur in vascular retinopathies, detachment, macular pucker, macular holes, trauma. But in this, we'll discuss the art of membrane dissection primarily in vascular retinopathies. And the term dissection is appropriate as these membranes are nailed to the retina at the various vascular attachments. These attachments may vary from single to multiple to long linear adhesions along the large vessels, and the clinical picture can vary, as we'll see from this kind of active neovascularization here with these multiple points of attachment. The vascular attachments to more fibrotic situations. Here it's an end stage kind of a situation with subretinal fibrosis as well, and the tabletop traction retinal detachment. Here this is been converted into a combined detachment because of a break which is formed at the base of one of the fibrovascular prolifs, so we can have a combined retinal detachment. A general principle for any dissection is that you should be in the correct plane. Being in the correct plane makes a difficult case simple, and conversely, being in the incorrect plane can make an easy case tough and messy with intra and post-operative complications. And the degree of difficulty depends on the extent of the fibrovascular proliferations, the separation of the posterior hyaloid between and beyond the areas, as we'll see later, and how tightly it is adherent. To find the correct plane, you must be aware of the phenomenon of vitreocysis. This was a very landmark sort of description, where this is the what looks like the PVD is actually the schisis cavity. It's only here that the hyaloid is separated. So this is something you have to be all the time conscious of when you do vitreous surgery, especially in these cases, is to find the correct plane. And in these few little animations, we'll see the progression of the different types of pathologies which we see. So here we see the neovascularization developing and sheets of fibrovascular tissue there, and it could form a sort of a C pattern here, or an entire ring, or in the more advanced cases go on to tabletop traction retinal detachment. In this next one, we see how this phenomenon of vitreocysis happens. The vitreous gel is there, the cortex here, and the retina, and the bleed here kind of dissects the vitreous cortex into an anterior layer of the vitreous cortex, as we'll see here, and the posterior layer which is still adherent to the retina. And that's the vital thing. You have to be aware of that posterior layer, and you have to get underneath that when you do proceed with your dissections. Here we see that's the schisis cavity with the anterior and posterior leaf of the vitreous cortex, and then once this contracts, it produces a traction retinal detachment. In certain situations, either you develop this sort of huge sheets like that, as we saw in the earlier one, or sometimes you have this more localized, but also you can have a centripetal contraction of this tissue which can throw the retina into folds. And again, when you are dissecting, you have to be aware of these folds here to be able to remove this tissue accurately and not cause trauma to the underlying retina. And in this situation, you have this converting into where we saw in the earlier pictures, then the fundus photos, that a tear forms at the base and converts this from a traction into a combined traction rhegmatogenous retinal detachment. So in the principles of the membrane surgery, either you can do a segmentation in which essentially you are breaking up this tissue into smaller and smaller bits here, and with my MIVS actually you can almost approach delamination, as Dr. Gopal Pillai said, with your instruments itself. And in delamination, you are removing this entire tissue by cutting each vascular nail or connection and removing the tissue in toto, which is actually the more ideal procedure to do. Now, here in the finding the plane, as I said, this is the anterior leaf of the vitreous cortex, but the posterior leaf is still adherent. So it's important to get an opening into that tissue, as we'll see later in a video. And you shouldn't be in this plane, but in this plane, and then your dissection will proceed more efficiently, atraumatically, and with complete removal of all the fibrovascular sheet of tissue here. You can use 2 chandelier lights for the bimanual, but nowadays with the torpedoes we used to use 2, but with the chandelier illumination now, which is really very good, often 1 light suffices. And what you are doing is actually using a combination of peeling, because where it's less adherent it tends to peel, and whenever you encounter an area of resistance or a broader area of vascular attachment, then you must cut that with the scissors. And with that you can remove this entire tissue. So we'll just see a couple of videos now illustrating all these. To start with, sometimes the hyaloid is separated over the posterior pole, so you start from here, get an incision into that, and then gradually extend this along the temporal raphe. Once you've done that, then you can produce traction here both superiorly and inferiorly to separate the hyaloid all around, like 360 degrees circumferentially. This is an old vitreous hemorrhage, a long-standing one, where this again appears to be the posterior hyaloid there, but that's again the anterior leaf, and it's the posterior leaf is coming off later, as you saw with a wave there. And it's only then that when you've got that sheet off that you can excise the rest of the tissue. Sometimes you have these anterior extensions, and that makes the case very tricky, especially in a phakic eye. And sometimes if they are very anterior extensions, we even plan a combined phaco just for that, even with a clear lens, to be able to tackle the entire anterior extensions and to be able to separate the hyaloid very anteriorly. So it's important that you must separate the hyaloid peripheral to this fibrovascular tissue, and only then you will be able to again excise all this fibrovascular tissue from the surface of the retina completely. This case very classically shows that what was shown in the animation also. Here we start dissecting here, but this was the incorrect plane. You're actually cutting into the tissue, and this is the posterior leaf of the vitreous cortex here, which you got left behind, and then the traction raised that edge, and when you got actually into that edge, now you see how quickly and atraumatically the dissection proceeds, because you can accurately see every vascular connection and cut it as you encounter it. And now you proceed this way and then remove the entire tissue. And this is the last video now. This is showing a combined retinal detachment. You see the retinal break here. It's important again to separate the hyaloid peripheral to that, to be able to remove the entire fibrovascular tissue. There must be no residual traction left on that break when you've completed the case. Here we removing the tissue bimanually. And once that is done, now you can see that it's removed there, and then you do the endodrainage and complete the case with a fluid air exchange and laser around the break. This was again a similar combined retinal detachment, which was managed with a 25 gauge vitrectomy. And here what Gopal was mentioning about how the smaller gauge instruments, you can actually insinuate the cutter and use it for a lot of your dissection. And you need to do the bimanual only for areas of very broad adhesion, where the membrane is tightly adherent to the retina over a very broad area. As you see here, this broad area, this could not be done with just the cutter. So here we shifted to the bimanual and the contact lens to remove this tissue from the surface, and that was the end of the case. So with that, we come to the conclusion, to the end of the talk, and I'd like to invite you for the DOS annual meeting in April 15th to 17th, all of you, and also in the December of 17, the World Congress of Pediatric Ophthalmology and Strabismus is planned along with the DOS winter. So welcome to you all to join in there. Thank you for your attention.
Thank you, sir.